I promise everything I'm going to tell you is true. We've created quite a buzz with this GHRP6 protocol that we're working on. And I just have to tell you, everything I'm going to tell you about right now is absolutely true. So, remember back in the 1970s when 7-Up had the commercial with the brother who, with the lemons and limes, and they had the commercials, and he talked about the Un-Cola? Well, since we're having so many problems with growth hormone, frank growth hormone administration due to the regulatory interference, we've been able to come up with a way to elevate growth hormone and actually do a much better job of it for a fraction of the cost. And that's what we're going to talk about today. Those of us who are at the cutting edge see the impending storm, not just because of changes in healthcare thanks to Obamacare, but also because we're going to have increased regulatory interference in what we're trying to do. I do wish they would just plain get out of our way. Just like when the Pharaoh demanded that the Jewish slaves increase their production of bricks, but then took away the straw that they needed to make the bricks, they found a better way to make bricks without straw. We have found that it's much better to replace growth hormone, to restore a hormone, than it is to replace it. I'm assuming everyone here is hip to the fact that low and even low normal growth hormone levels are deleterious to both our health and our happiness. If anyone here doesn't, welcome to A4M. Fortunately, as we age, our ability to restore growth hormone production endogenously is not decreased. Just a little bit about growth hormone. It has a really short half-life. Everyone knows, as a review here, it's released in a pulsatile fashion. We have to measure it, therefore, indirectly through IGF-1, which is produced by the liver under growth hormone stimulation with some variability, but IGF-1 has a short half-life. However, it forms a ternary complex with IGF-binding protein 3 and acid labile subunit, and that draws it out to about a 20-22 hour production status post-growth hormone administration. The problem when we administer growth hormone replacement therapy is that we inhibit our own production, the same with testosterone replacement therapy. And over time, the somatotrophs that we're producing growth hormone now begin to produce prolactin, because one of the two major forms of growth hormone we naturally produce actually has a prolactin piece inside it and binds the prolactin receptor, which is why you'll see growth hormone-induced gynecomastia in some men. And as the growth hormone production ceases endogenously, these somatotrophs begin to produce prolactin instead, and that is an issue. Later on, there's actual disease atrophy. But growth hormone production can be restored unless you have an episelica. The problem with growth hormone replacement therapy, as we well know, is it's expensive and getting much more expensive. Tachyphylaxis is possible, and at this point, I'm just considering, for all practical purposes, I'm not messing around with it. I haven't prescribed it in years. I'm not going to worry about it. I just consider it to be illegal. So, growth hormone production is regulated by growth hormone-releasing hormone, ghrelin, which is the hormone your stomach produces when it's growling. It's interesting always, as we study how the body works, that as your stomach growls, it produces ghrelin to make you eat. I'll talk a little more later about what I call the ghrelin effect. And then it also causes the pituitary gland to produce more growth hormone, so we may receive the blessings of the food that we have just consumed. And then somatostatin is the inhibitory factor. I have a picture here of our pulsatile growth hormone production. And you see, here's a peak of production, here's somatostatin dropping it down. Then another peak of production, there's somatostatin again. You notice if you look here between the young folks and the old folks, none of them are here in this room, of course. You see, not only do young people produce more growth hormone, but it's also much more variable. We're finding, especially with respect to the neurotransmitters, that variability is part and parcel of youth. And that, for instance, is why I vastly prefer transdermal testosterone for testosterone replacement therapy than, for instance, injectable testosterone cypionate, because the variability greatly, just so it doesn't walk away later, thank you, greatly aids our health and happiness. So, somatostatin, which is also called growth hormone inhibiting hormone or somatotropin release inhibiting factor, is produced by the hypothalamus and other tissues, by the way, but inhibits growth hormone synthesis and release. It basically makes the hypothalamus resistant to the stimulation by the growth hormone-releasing hormone we produce, or by hypoglycemia, etc. And as I just showed you, it's responsible for the pulsatile growth hormone inhibition. Of interest, it decreases the number of somatotrophs that produce growth hormone, but does not decrease the amount of growth hormone is produced by each. The problem with somatostatin is that production increases with age. It also upregulates its own receptors. And those of us who have gotten past 50 years old, as I have done a couple years ago, was saying that's probably why not only do we get old faster, we get older faster and faster. So, this growth hormone releasing hormone, which is produced by the hypothalamus, stimulates growth hormone synthesis and release. That's why it's called a releasing hormone. It binds to its own receptor in the pituitary. There are two distinct pathways we're talking about here. This is one of them, the growth hormone releasing hormone. It also has a very short half-life of interest to some people. I guess it increases the number of somatotropes and also the amount of growth hormone from each of them. What's interesting is that there is no downregulation with supplementation here like there is with growth hormone. If you give growth hormone, you decrease endogenous production of growth hormone. It's not the same here because we are now stimulating the pituitary gland to be nice and plump and productive. But its natural production is inhibited by fatty acids. And I want you to remember that, please, because when we're talking about using Sermorelin, which is growth hormone releasing hormone, is that a fatty meal will inhibit growth hormone production. So in the evening, you've got to keep the fat intake down, and probably the rest of the day as well. There's a picture of those who like that kind of thing. So Sermorelin is an analog of growth hormone release hormone. It's the business end 29 N-terminal amino acid chain. It also has a fairly short half-life, and it is typically injected sub-Q, right before you go to bed at night. The idea is then is that we're tying it right on the natural production of growth hormone we get at night, trying to synchronize with our body's natural rhythms, especially wonderful using melatonin, by the way, which I'm really into. Now, we have 30 years of data about it, so it's well known and well studied. Of interest, it upregulates its own receptor, and we like that. There can be antibody formation, but it's transient and non-neutralizing. It promotes that good non-REM slow wave sleep. And also, and this is important when testing, if you're using Sermorelin to increase growth hormone, you have to appreciate that you'll get harmonics of growth hormone production throughout the day. So your IGF-1 may not be as high when we traditionally measure it in the morning, but the area under the curve for the entire daily production is wonderful, which is why I greatly favor a 24-hour urine test for growth hormone production. Then we get the area under the curve. Can't hide anything from a 24-hour urine panel. However, the Sermorelin is vulnerable, as we talked about, to the physiological feedback. And as we talked about just a minute ago, such as fat intake. Well, of course, growth hormone replacement therapy is not, because you're just injecting frank growth hormone. And this is an issue that led to the real problem why I'm now dismissing Sermorelin. That'd be a news flash. The effective dose of Sermorelin, by the time you get up there, pretty much is rising up close to that growth hormone, much higher than it needs to be.